Good evening, everyone. My name is Carver. I am a product specialist here at Oculus, and welcome to tonight's clinical webcast, Oculus CSP Report Pro and WAVE contact lens systems, fitting scleral lenses on patients with severe pathologies. You have a text box on your GoToWebinar screen where you can enter in questions, as this is a more in-depth kind of webinar talking about scleral lenses. Really get your questions in early. I'm certain that there will be a lot of them tonight, and we want to be able to get to all of them. Our speaker tonight is Dr. Ken Mahler. He earned his doctorate from the Illinois College of Optometry and currently is in practice in Fort Lauderdale, Florida. His practice is devoted to orthokeratology as well as providing visual rehabilitation for irregular corneas. And to be perfectly honest, he sees some of the most interesting cases that I've had the pleasure of seeing. Not only is he an expert he's one of the foremost wave contact lens designers in the world, he's also been using CSP and CSP Report Pro since it's been all the way back in its beta. Dr. Mahler lectures extensively on contact lens design as well as providing clinical consultation services. He is a fellow in the American Academy of Optometry, a fellow in the International Academy of Orthokeratology, a diplomate in the American Board of Optometry, and a fellow in the Scleral Lens Society. Dr. Mahler, it's always a pleasure to have you on for one of these webinars, especially for one that I'm so excited in, dealing with these more complicated cases, these patients with severe pathologies. Take it away.
Well, thanks a lot, Carver, and welcome to all of you out there who are attending the webinar tonight. Thanks for coming out to listen to the presentation tonight. Let's just get started here and see how things look. Oh, if things will work here. First, a disclosure: I do consult for both Oculus and WAVE. I am in private solo practice in Fort Lauderdale. It pretty much is a contact lens only practice. I have no glasses in my practice and don't really deal with anything outside of anterior segment contact lenses. It's devoted primarily to irregular corneas with okay myopia management. I do formal lectures for WAVE over the years and instruct practitioners out there. But in addition to that, I also do offer private practitioner consultation services, and that's fairly varied as to the avenues that are available to you guys out there, both by case, one-on-one training, phone consultation, as well as just remote fitting. I do the beta testing for some of the software, and I've had developmental input for the CSP and WAVE and the AXL WAVE. And I'm continuing to guide the WAVE education and software development. All right, let's get into the lecture for tonight. So we're going to be talking about the AXL WAVE, and I thought we really need to start off with the basic fundamentals. So obviously, you want to go ahead and get yourself a great Pentacam CSP PRO scan, and once you have that, you really have some wonderful data to design up a lens from. And how would you go about doing this? Well, these are the basics. You have to get the patient comfortable because they may be sitting there for a little while. You definitely want to get the lids out of the picture. They are of no help to you in designing up the lens. And definitely give the patient very clear instructions for what they need to fixate on when you're doing the scans. And then get proper training for the operator. I know the majority of practitioners delegate out the scans to their techs. I personally take my own scans and have a tech assist me when I'm doing that, which does have a couple of advantages and something you may want to consider. I do know it's sometimes difficult to work that in with patient flow, but one of the things that I have an advantage of by taking my own scans is I know exactly at the time of the scan if I have data that's captured that's appropriate for designing, or if I need to repeat the scan. You would be the best one to assess that, and although you can teach a tech certainly to be able to assess whether the scan is acceptable or not, no one's going to be better at it than you. So that is something that may save you grief down the road if you are taking your own scans. This is something that I discovered early on with the CSP software. You absolutely need 4 hands to do the scans. And that, in my case, is I generally am operating the Pentacam, and I have a tech who are holding the lids out of the way for the patient. You can try and do it by a single person, but it is really challenging to get good scans, and especially once the cornea starts becoming irregular and you are starting to push the Pentacam to the limits there as far as what it can capture and what makes sense to its software. Getting another set of hands in there to help out is, in my experience, has been absolutely mandatory. Okay, so here we have a scan. This is a typical CSP PRO scan, and this was on a PKP patient. They had the transplant due to keratoconus, and what you can see is I've captured that all in one single capture. That's one of the nice things about the CSP PRO scan, is if you can get the eye open wide enough, you really can get the patient scanned in literally 2 seconds and have all of the scleral data that you need so that you can go ahead and design up a lens. If we take a look at that particular patient's scan, you can see in the upper picture there, I have the cross-sectional selected on the vertical meridian. That's number 6 there. It's virtually 90 degrees. And that was so that you can see the cross-section right below that, that in the vertical dimension, just how far the lids retracted off the corneal surface. Unfortunately, not every patient can get their lids that far out of the way in that vertical dimension, but because this patient was able to do that, and again, that was with help from tech, this only really required one single scan to capture this. Here is a post-LASIK patient, and what you can see here is I did a double capture. The first capture is that sort of golden yellow color, and you can see that I captured the majority of the central data and a good portion of the superior data on that first capture. And then on the second capture, I filled in what I didn't get on the inferior portion of the sclera, and that's that turquoise color that's down at the bottom. On this one, this was a keratoconic patient, and once again, you can see here, I did not capture this in one, but actually took 3 captures. The first one, again, being that central one, but on this central one, I was not able to get the upper lid out of the way enough. And so I went back and took that superior scan, that's that turquoise colored scan up on the top. And then I had the tech pull the lower lid out of the way and took the bottom pink portion of the scan on that particular patient. You see here on this particular post RKI, I did the exact opposite. It was still a triple capture, the first one being the center, but my second one, I pulled the lower lid down to get the inferior data, and then on the third capture, I went ahead and pulled the upper lid up out of the way and got the superior capture. That was that pink arc up at the top there. This is a post-RKI, and here's where things start to get a little bit dicier. You can see that the capture is not nearly as clean looking as the previous ones. My first one, I was able to capture a great deal of the central and inferior portion of the cornea, but there's a little wedge chewed out of that. Tough to say why, it's something on that particular cornea. I then took a second capture, which was able to get the superior arc, but I still was not able to get out as far as I wanted to. So I took a third capture to get a little further out in the superior area here so that I would have enough data to design up that lens superiorly. Now here, we're starting to see on this keratoconic eye capture that's certainly not as clean looking as the previous ones that I've just shown you. You can see here I did a double capture. The golden captured the center and superior portions, but not entirely. And then the second one captured the inferior, but despite that, I'm still missing an enormous amount of data down there. 16.4 is the millimeter I was planning for this lens, and at 16.4 millimeters, you can see I have no inferior data showing up on the sagittal depth there because of the fact that I missed all of that data down there. This was not a lid in the way. The picture down below that is deceptive because that was just on the first capture. The lid was absolutely not out in the way of this picture at all. It was purely a data problem. So what do I mean by a data problem? Well, if we take a look over here on the elevation map, you can see there that where the cone is, we have an elevation of about 183 microns at the peak, yet just below that we have a depression of 377 microns, which means that the cornea is taking a 0.5 millimeter dive down right there at that spot. And as a result of that, the continuing area inferiorly is getting very, very steep. And basically the Pentacam is saying, I don't think that that's real because that seems bizarre. Obviously it's not bizarre. This particular patient had that, but this was not an operator capturing problem. This was purely a data problem, and the data was not being processed correctly because it just seemed a little too outrageous, and so it just wasn't processed, hence the lack of data down there. We can see over here on the ARC screen that's on the left there, those profile scans, down at the turquoise section, just how sharply down those turquoise arcs are heading toward the bottom here. And again, that's indicating that very, very steepened inferior portion of this eye, and hence that's the reason why we weren't able to capture the data out there. Let's take a look at this particular eye. This one is on a post-RK eye, and once again, you can see my capture is not really as clean as I liked it to be. I did do a double capture. You have the central one, which captured a good portion of the central, but I did miss some of the superior portion. And then inferiorly, once again, I've missed a whole section down at the bottom of that. If we take a look up over here at the 15.7 millimeter cord, which was what I was planning for this particular eye, in the superior temporal, the sag at 15.7 is 5,131 microns, yet the sag 180 degrees away at the inferior nasal at that same cord is 4,137, which is a difference of about a millimeter. So we have a very, very dramatic difference between the superior temporal and inferior nasal sections on this eye, which even if we're capturing all this wonderful data, that's going to present certain fitting problems for us because there are limitations as to what can be manufactured on the lathe as well. So this is something that you definitely want to take a look at, but it's understandable as to why I was having the problems that I was having capturing this particular eye. So now if we take a look at a Scheinflug image, we can take a look at this, and that's a very normal looking cornea. There's nothing unusual about that particular cornea. But our previous fellow, that post-RK eye, you can see just how ugly this particular cornea really is looking in cross-section. You can see that the central portion of the cornea, as is very, very typical with RK, is incredibly flat. That looks almost like a totally flat plane there. And then, of course, on the left-hand side of the picture, you can see actually one of the RK scars that's created a little bit of a dip on the front surface as well as on the back surface of this particular cornea. Looking at the normal versus the RK eye, with the normal one being on top and the RK eye being at the bottom, you'll notice that in the iris image there are the Purkinje alignment dots to the auto capture. This is in fact how the Pentacam knows that it's aligned along the visual axis. It takes a look at those Purkinje images, and we can see on the normal upper picture that those Purkinje images, those four reflected dots, are focused very sharply and they're equidistant from each other. If we take a look at the RK eye, we notice that they're not simultaneously focused and they're not equidistant from each other. And here, this presents another problem for capturing on these particular eyes, where the Pentacam is not going to auto capture because it's having a difficult time identifying exactly where the visual axis is, because these Purkinje images are not lining up where they're supposed to be lining up. Take a look at this particular eye. This is a keratoconic eye, and we can see on the left-hand side there that there's a fair amount of scarring on the anterior portion of the cornea, and it does drift down into the stroma somewhat as well. If we take a look at this particular eye and the Purkinje images that are being reflected off of the cornea, once again, they're not simultaneously in focus. You could see the lower left one is perfectly in focus, yet the other three are all a little out of focus, with the upper left one being the most out of focus. And again, they're not equidistant. Additionally, I overlaid what the topography looks like there, and you'll notice that the two Purkinje images down at the bottom are virtually dead center on the peak of the cone. The reason for that is that this particular eye is scarred there, and the scar is very, very bright, and as a result of that, Purkinje images are reflecting brighter off the scar than they would off any normal cornea. This is now leading the Pentacam to believe that the corneal apex is down lower, which you could see, that's that little center dot in the middle, is not really coincident with really where this fellow's visual axis is. Okay, so let's take a look at the case report now that we understand why we'll run into some capture problems. And let's take a look at the history of this particular patient that I chose to present to you tonight. This is a 68-year-old female. Her name is S.A. And she was actually a traveling companion of the patient. Now, I want to give you a little backstory on this. This particular patient did not come to see me. The son came to see me. They had traveled in from another country. And the reason that they had come in was that the son has rather advanced keratoconus. He is scarring as a result of the piggyback lenses he's wearing. He's had a soft and a corneal GP on top. And his doctor in his country had suggested that he get out of the piggybacks and into a pair of scleral lenses so that we can get the lens off the cornea and hopefully the scarring would not get any worse. He's, I believe if I remember correctly, he's about 40, 41 years old. And so he got in touch with me because after failing every scleral lens in his country and with multiple doctors, he was feeling very defeated by all of that and kept going back to the piggybacks. But he did reach out to me, and I said, sure, if he doesn't mind traveling in to see me, I'd be happy to take a look and see if I can get a scleral lens on his eyes. And he had planned that trip to come and see me with his wife. Well, at the last minute, his wife had decided she didn't want to come to these states and into Florida. And so he had asked his mom if she wanted to join him just to keep him company. And so she came in just as a companion for the son. Now, what happened is, in the first week, they were only here for about 10 days. It was roughly a Monday through to the following Wednesday. The son, in the first week, I had do very, very well with the scleral lenses. We weren't quite finished yet, but we were very, very close after the first week's worth of work. I looked over at the mom, and I said to the mom, who was sitting there with a pair of glasses and her eyes half shut, do you have keratoconus? Since they do, it does run in families. And he said, oh, yes, I do have keratoconus, and I've had a lot more than just keratoconus. I said, really? Do you see well out of those glasses? And she said, no. I said, oh, that's interesting. Maybe we should get you in for an exam and take a look and see what's going on with you. So she thought about it over the weekend, and she decided on Monday that she was going to let me examine her, even though she was leaving the following Wednesday, 2 days later. So she has keratoconus. Her glasses are, as you see there, 5 diopters is shown on the right and a progressive, and that gave her the wonderful acuity of 20/80 minus, which was her better seeing eye out of the glasses, because the other eye only had finger counting vision at 2 feet. It was just a balance lens. She had bilateral PKs. They were both 20 years old. She had also had bilateral cataract surgeries with implants. The right eye about 7 years prior, and the left eye about 6 years prior. Prior to the PKs of 20 years ago, she had a very successful history of hard lens and GP wear for better than 20 years. As soon as she had the PKs 20 years ago, she lost all usable vision in the left eye, and both eyes were unable to be successfully fit into any corneal GP or scleral GP. The patient told me she had absolutely been traumatized by all the scleral attempts because they were so painful, which is why she came in wearing the glasses that gave her 20/80 minus in the only eye that she had. So if we take a look at her scans, you can see the right eye is on the top and the left eye is down at the bottom on these Scheimpflug images. And we can see from the CSP report of this eye here, I was able to do a double capture, which is pretty nice, the central capture and the inferior capture. And at a chord of about 15 millimeters, which was what I had been planning for this lens design, I actually got very nice data from the Pentacam to design up a wave lens for him. We take a look at the left eye, and we can see the left eye is not nearly so pretty as the right eye was. First of all, we can see I did do a double capture, and that was not just 2 times. I tried multiple times to get data on that, and this was the best I was able to do. You can see there's an enormous amount of data missing from that. Has sort of that whole broken tooth type of appearance there, where we're missing big swaths of data in large sections over there. And so that's going to be the first problem in trying to get a lens designed. We have no data whatsoever. You can see by that dotted circle that I'm even missing corneal data. Forget the scleral data. I'm missing a good section of corneal data in the inferior nasal portion of that cornea. So that's the first problem. Second problem is, as far as the scleral data goes, it's blank. There's no data whatsoever. So I have absolutely no sagittal data to even guess as to what I need to put on this eye. Bear in mind that this is a Monday and she was leaving on Wednesday. So I at least wanted to get something on her eye. All right, so if we take a look at the left eye CSP report of this particular patient and we compare it to a normal right eye CSP report, we see a couple of very interesting things about the CSP report. First, draw this line at the apex over here for reference. And so I've just drawn that to kiss right at the apex of both of these eyes. You can see here that I have compared up the superior nasal and inferior temporal reference arc of both eyes within 8 degrees of each other. So they kind of mirror images to each other, so we can get a good sense of what's going on one side versus the other and compare them. That turquoise line is denoting a 15 millimeter cord, which was the cord that I was planning on using to design up this 15 millimeter scleral lens. We can see where it intersects the normal cornea over here, and we can see the difference of how it's not intersecting the cornea on the left eye of this particular patient, but her cornea is actually considerably steeper and lower down. I went ahead and left-clicked on that so you can get actual data measurements, and you can see at that 15 millimeter cord on the normal eye, we have a sag of 4274 microns. On the left eye, however, at that same location, we're at 6038 microns. That's almost 2 millimeters deeper down than it is on the normal eye. I didn't show it here, but I did grab the value, and you can see just by eyeballing this that the normal compared to the this particular patient left eye on the nasal side, they're fairly similar on that superior nasal intersection there, and the patient's was just a little bit steeper at 3941 microns of sagittal depth at that 15 millimeter cord. But this is the second problem. The superior nasal sag is 3941 and the inferior temporal sag is 6038. That's greater than a 2 millimeter difference between one side of the eye and the other. This is a retroillumination of a normal eye, and that was that right eye. And if we take a look at this particular patient's retroillumination, you can see it's very, very dark. Now remember, she's a pseudo-fake, so that's not a cataract. It's a very clear lens that she has implanted. So the question is, why is that so dark? Well, the reason it's so dark is because there's a lot of corneal scarring that we have on this. And so this is yet another problem that we're going to have to deal with on this left eye. What I find is very helpful to understand corneal scarring is the densitometry. And I do know that not every Pentacam package has densitometry. For those of you guys who do have it, I find this tool is actually very, very valuable to understanding what you're up against in dealing with these very complex pathological eyes. So just to understand a little bit about this screen, we can see in the upper left box there, that's a cross-section of the horizontal. And we can see here is a cross-section of the vertical cornea. And of course, this is the normal cornea. They sum total over here on that big box. And essentially, you could think of that big box as anything that is reflective off the cornea, such as an opacity, is going to be whiter. So the darker that this image appears, the better the quality of transparency for that particular cornea. The whiter it is, the more reflective the cornea is, and that's going to prevent light from getting through this cornea. And obviously, the higher those numbers go, the worse that would be. So that's how you would read that information there. If we take a look up over here, there's another little handy tool there that gives you the ability to use two different layers. On this particular one, I have them both set at the anterior surface, so you can see that there's no difference between the two, and they're just talking about the very anterior surface. But if you wanted to find where in the cornea's layers the scars happen to be the worst, you can actually separate those two, and that would give you a good sense of where they're located in the depth of the cornea. Coming over on the right-hand side here, the one with the two blue arcs, one is a solid line and one is a dotted line. That's taking a look at this very same phenomenon, going through layer by layer and determining where, in which layers, there is the most reflectivity as well as transmissibility. The more the solid line is to the left, the more light is getting through the cornea. The more the solid line is to the right, the less the light is getting through the cornea. And going from the top, where it says 0.0 on the left side of the graph, down to the, in this case, about 550 or so, is referring to the depth of the cornea. In this case, it's about a 550 micron depth cornea. And you can see how it transmits through all of those layers, with the most reflectivity really up at the top little portion of that blue graph. The dotted blue line on the right-hand side is something that's taking a look at wherever the maximum reflectivity is, how much reflectivity is coming from that particular spot. The solid blue line is really the entire corneal average. So that's actually the more important value that you want to see. And again, the more to the left, the better that we can get light through. The more to the right, the worse it's going to be to get light through that eye. Now, similarly, on this lower graph with the red lines, once again, we see a solid and sort of a dotted line. It's a thinner red line up above. And again, it is taking a look at both the average reflectivity or density of these opacities with the solid line. And you can see it's hovering right around 20%, almost all the way out to 10 millimeters. But this is doing it from center to edge in concentric rings. So the center is the apex of the cornea, and it's certainly going to be within the visual axis. And the more toward the right you would go, that's going to be more toward the limbus. You could see that we get a little bit more opacification as we go out toward the side, which is very typical as you start getting some of the deeper layers of the cornea to interfere with some light transmission. Going up above here, that gives you actual numerical values. On the left-hand side, you have that anterior, center, and posterior dividing the cornea into sort of the top layers, the middle stroma, and then the back layers. And you can see on this particular eye, the highest numbers going straight across the border are in the anterior surface, kind of the epithelium and Bowman's membrane, which corresponds to that blue arc that we're seeing on the right. That's sort of poked up a little bit toward the 100%. And then we can also see on the lower portion of that, the sum total of the averages of each of those concentric rings. And so again, the 0 to 2, which would be the central, it's averaging at about 21.2, but it is the most reflective at the anterior surface at 28.9. Up on the top here is kind of a sum total, and this just takes a look at the maximum density of any particular opacity. And down at the bottom there, where I just circled, that's really the telltale value of how much transmission you can be able to get through the cornea, with normal corneas being typically right around 20%. So you can see this is averaging sort of right around 20% up until we get out to that 10 to 12 millimeter annulus, which is going to be much closer to the limbus. Let's go on to this particular patient, and you can see things look very different here. This is certainly not normal. That up on the top here, we can see that we have the scarring in that white reflectivity, both in the horizontal and in the vertical. You could see in the major picture that this is a much whiter appearance, and you can also see by spotting some of those numbers from the center at 36.7 out to some of the higher numbers in the 50 range there, that this is a much more reflective cornea. Over here, again, I still have the layers right up at the anterior surface because that's where most of the scarring is. But if we take a look here, we can see the entire solid blue line has been shifted a little to the right. Again, with the bulk of the scarring up at the anterior layers of this particular cornea. Here on the annular assessment, it's fairly equal, stretching from center out to edge at about 8 millimeters where it starts to increase. But if we take a look up over here, we can see it really is the anterior surface that's accounting for the bulk of the reflectivity. In the central layer, it's 71.6. That's all going to be shown up over here, where the maximum in some of those areas it's at 100%. And you can see that she's kind of hovering somewhere about 45 to 55% from center to edge in terms of how much is being reflected off, hence that dark retroilluminated image that we saw. In this particular image, this is the same patient, but you will notice now that there's two red lines there that are separated down to in the center about 310 microns, and that's because on both of these, I went ahead and tried to concentrate layer 2 down a little bit further into the cornea so I can get a sense of where the bulk of the scarring is from the very anterior surface down to that second red line. And now you can see on the major picture there that we've had all of that reflectivity really confined to that anterior surface. This is the average of the scarring, or how much light is coming through that entire cornea. And again, this is just another prominent we're going to have for this particular patient's left eye as far as pulling any vision through, because we're having trouble getting light through this particular cornea. This here was a patient who just happened to have come and visited me while I was preparing this lecture, and I thought it was very interesting to see on this one. This is a 70 to 75% scarred patient, and you can see I've used the color coding here to kind of highlight exactly what's going on. And we have here a very, very different picture. Unfortunately, centrally, we have scarring that is very, very significant. Certainly up in above the 60 percentile range over the entire center area, going through all those layers until it finally is a little clearer down at the back of the cornea. But you can see this cornea is also suffering with a little edema, being that it's 700 microns thick. You can see over here, center to edge, that the entire central 4 to 5 millimeters of this particular cornea has scarring that's somewhere around the 80 percentile range. And so he's averaging somewhere in the center at about 70–75%, and then it starts to thin out as we get out more toward the edge, which obviously is unfortunate because of the fact that we're dealing with the visual axis being compromised by this scarring. Okay, and this happens to be that particular eye. And we can see that this was secondary to an infection, and that's actually what the eye looks like with that big white scar that's covering really the visual axis. Okay, so now back to our patient here with the 45 to 55% scarring. This is the Scheimpflug image, and I picked the horizontal image just so we can take a look at the nasal and temporal. And remember, we didn't really have a lot of good data out on the sclera. So we're going to have to try and figure out some way to figure out where to land this lens on the eye. What I did on this bottom picture is I took the top picture, rotated it exactly to a mirror image, and superimposed it on the bottom. So we can see here that I've labeled the original, and that's, you can see on the left-hand side, the upper, and on the right-hand side, the lower, and superimposed it the other way around, just so we can get a sense at the same location, the difference between the nasal elevation and the temporal elevation. And you can see that is very dramatic, and that accounts for that 2 millimeter plus difference that we had on that, that previous map that we had seen. What I did here is I went ahead and picked that horizontal Scheimpflug image. That's the one we just saw. I decreased the brightness to the best detect where the scleral's anterior edge was, so I could best determine exactly where that was in space. I went ahead and drew that 15 millimeter chord to just about kiss the corneal surface at the apex. And then I went ahead and dropped the perpendicular down so I can get some idea about where that is in space. At the 180, we have a 4,395 micron drop, and on the temporal side, we have a 5,030 micron drop. So looking here at the topographical data, you can see there's a lot of extrapolated data being represented by all those little black dots over there. But even with all of that extrapolation, we can see that the inferior corneal quadrant is significantly depressed, which is confirming exactly what we had seen on those CSP arcs and the Scheimpflug image. Down up over here, you can see just how deep down that is going, and certainly it has nothing in common with really what was going on superiorly at all. This is the older WAVE software, and one of the problems that you have when you have corneas like this with data that's not stellar is that when it gets fed into WAVE, WAVE is going to have a tough time dealing with the data as well. And you can see this was certainly no exception. The cornea looks truly bizarre over there. This was along the horizontal, and this was what the WAVE screen looked in the vertical. And you can see the vertical, even though the cornea looks so bizarre, it's still trying to show you how depressed that cornea is. Now, one of the problems that I've had with the older software is that when I would deal with a cornea like this, it's not uncommon to go ahead and make a change and watch the software crash. So what I adopted as a procedural way to deal with that so I can get to a lens design is I basically would make one change, save the lens, make another change, and if it crashed, I would open up, but I'd be one change closer to finishing the lens. This particular lens I did try to design with this software, and I could never get to the end because it would not allow me to design based on all of this data that was obviously difficult for WAVE to handle. So I went ahead and designed it on the new software. And I will say that one of the nice things about the new software is during my entire design process, it only crashed twice, which was really fantastic because it let me get to a design pretty quickly. Horizontally, we have the 180 and 000 meridian represented up over here. And nasally, we have a sag at the edge at 5468 microns. On the temporal side, we have 5353. So despite the fact that it appeared about 700 micron difference on the cornea, you could see my lens only has about 100 micron difference between the nasal and temporal side. On the vertical, we have here on the left side, that's the 270 or the inferior, the one that had that very, very deep depression. I have a sag on the superior side, 4922, and on the inferior side, 5301. So again, about a 400 micron difference between superior and inferior, not the 2 millimeters that I was measuring off of the screen. However, I felt that that lens looked pretty good as a good place to start. And so I went ahead, ordered the lens, got the lens in for that Wednesday, and got the pair of lenses on. I've included the right lens here just for the sake of completeness, but I'm not really going to talk much about the right lens. Acuity initially with the lenses was 50 minus on the right and 2400 on the left. But with the over refraction, look at those numbers. I was actually able to get the right eye down to 20/25 plus, which was a far cry from the 80 minus she was getting in her glasses. But the real shocker was the eye that had no vision for the last 20 years is actually capable of getting somewhere around 20/30 minus with a spherical over refraction of -4. The lenses appeared well centered. The right one, 125 microns of apical clearance. The flange was aligned very nicely, no rotation noted. The left one was well centered. I had a little more clearance on that eye. However, there was a slight inadequate amount of limbal clearance entirely around the lens. Good flange alignment, but there was a little bit of excess sag superiorly and a little bit of inadequate sag inferiorly, which really isn't a surprise given that my lens only had the 400 microns of difference between the superior and inferior, and I had measured something like 2 millimeters there. The patient was leaving later that day, so what I did was I ordered a new pair of lenses. She was incredibly excited to come back, but she wasn't going to be able to get back for about 45 days later because originally she hadn't planned on coming at all. So this was kind of out of the blue, but she was very excited about getting these lenses. She also did comment she was shocked about how much she didn't experience any pain. In fact, she didn't even know the lenses were on her eyes when I had them on her. So it was a very, very good first pair of lenses. On the second pair, I went ahead and took a look at the horizontal. We have, again, 52/30 and 51/56 on the nasal and temporal. And on the vertical, you can see I decreased the superior sag and increased the inferior sag. So on top of the 400 difference we had, now we had about a 600 micron difference between the top and the bottom. If we take a look at the quad view on the wave screen, what we can see here on lens number 1, you can see the limbal clearance is appearing to be ineffective on the lens design on the fluorescein map, and the edge clearance is kind of thin. So you can see on my second map, I did increase the limbal clearance as well as the edge clearance of the lens all the way around. You really couldn't see that from those sag values, but I did do this in the design itself. I also added the -4 to the over refraction on lens number 2 and waited for her to come back. So she came back, and yes, I did use Optimum Infinite because of the grafts. I was obviously concerned with oxygen, and got these lenses on, and 20/40 plus and 20/50 plus. She was absolutely astounded. She was actually able to see, and for the first time in 20 years, actually had some binocularity too. With an over refraction, though, here's the real shocker. We got the right eye to 20/20, and the left eye actually to 20/25 minus. I actually got it and given her a little too much minus. I had to dial that back a little bit to 175 plus. On the biomicroscope, the right lens fit very nicely. The left lens now had a little bit decreased apical clearance to 150. The limbal clearance was good, and I was happy with the flange alignment, and the lens was showing 15 degrees of clockwise rotation. Since we were on such a time crunch, I went ahead and dispensed the lenses. I taught her how to get the lenses on and off, but I ordered a new pair of lenses for her with the power change for the follow-up 5 days later, because she was going to be leaving the country again 5 days later. So this was lens number 3 for the left eye, and you can see I did not change anything on the nasal or temporal sides of this lens. On the vertical, I didn't change anything about any of that because I was actually pretty happy with what it looked like at the biomicroscope. The only thing I really did was I changed the power by adding in the plus 175 over refraction. I got that third lens on her, but she came in wearing the second pair of lenses, so I figured, let me see what's going on with that. She said she's seeing very nicely. She's very comfortable in the lenses. She's having a very difficult time getting lenses on and off. And at the time I saw her, the lenses were on for 3 hours already. Vision was 20/30 and 20/50. I was very happy with the right lens. The left lens, however, although I was happy with the way it was fitting, I noticed there was some inferior conjunctival prolapse. Took a couple of days for that to show up, and that was probably because I had increased the limbal clearance inferior a little too much because of that very, very depressed inferior portion of the cornea. I took the lenses off myself. They easily came off and there was no staining whatsoever. So the eye was fairly happy with the lenses. I went ahead and applied the new pair of lenses. Right eye was right on 20/20. The left eye was at 20/30. And again, for some reason, she took additional plus on that. That got it to 20/25. The lens looked really, really good on the right eye. The left eye, the only notable thing was I saw the conjunctival prolapse because it was there from the lens I had just taken off. So to follow up on all of this, I discussed the prolapse with her and the over-refraction of the 1 diopter. She was leaving the country later that day, so I couldn't do anything about it. She was leaving with that 3rd pair. She was planning on coming back in 2 to 3 months. I have not seen her back yet. It's only been about a month and a half or so since she picked up that 3rd pair of lenses. So I'm hoping she's going to show up hopefully later this month or possibly at the beginning of next month, so I can fix that. I ordered a new left lens by decreasing that limbal clearance to see if I can improve some of that prolapse, as well as I also added in the +1 refraction, over-refraction to that 4th lens. The lens is already in the office waiting for her. I RX'd her a pair of reading glasses, and I did do $250 on both because she said she was going to come back to get the +1, and she'd just rather get a pair of lenses, a pair of glasses that would work over the final pair, which would have been the 4th left lens. I instructed her to follow up with her local doctor if she has any problems whatsoever. So to summarize the case, Pentacam AXL WAVE has increased the ability to get the scleral elevation with the CSP PRO software through several advancements as compared with the standard CSP. First, the hardware allows a greater cord capture, as well as it's easier to capture data further out on the sclera. Due to the camera system in the AXL WAVE, even the non-CSP PRO central capture is typically 90% or greater at 15 millimeters. You do get a lot of good coverage and well past the limbus at that point, even with that central scan, which I found very, very helpful and very, very quick for doing my corneal lenses. The software also has improved its edge detection, so there's less data gaps when dealing with these very irregular surfaces, and of course that continues to improve. The CSP PRO software typically captures the eye to a port of 18 millimeters, and if you have a patient that we can get the lids retracted enough, you can get that accomplished actually in a single 2-second scan, so it's actually very quick and easy. Most commonly, though, I will tell you I take 2 scans per eye. Generally, I'll try and get as much of the central coverage as well as either the superior or inferior portion covered on the first scan, and then I'll go back and get whatever I didn't get on that second scan. There are times that are due to that scarring or very dramatic elevation depression differences that it's difficult to get that ideal scan. But if you understand the process of the capture and that transfer and processing of that data to wave, it still does provide useful data so that you can go ahead and design up a wave lens. There are several display screens and tools within the Pentacam software that allows you very different assessments from different approaches of the eye when the ideal scan isn't possible to obtain. Understanding the displays on the wave screen along with the ability to manually adjust the segments of the lens while taking into account the useful data provided by Pentacam, you can then go ahead and create that lens that's not going to be all that compromised even though you had a difficult scan. And all that combined with your skills at the biomicroscope, you can go ahead and bring success to these very challenging eyes. With that, I am done for the evening. I hope you enjoyed this and found some useful tips and tricks to get some better data, even when it's very difficult to get that data. And so we're going to go ahead and get some questions out there from you guys. So take it away,
Ken. Thank you for that wonderful presentation. It's always so interesting to see these really complicated and severe pathologies and how you're able to get an eye from basically being totally given up on and not seeing it all to such a wonderful state. All right, into the questions. If any of you have any questions you've not yet entered yet, go ahead and enter them now just so we can make sure we can get to them all. We have quite a few already. The first one I'll actually go ahead and respond to. For corneal densitometry, what numbers / metric is being used? I'll go ahead and answer that one. So a set amount of light is being shown by the Pentacam, and based on the contrast in the different images, the Pentacam is able to determine how much light is being reflected off the cornea and what percentage of that light is being reflected off the cornea is giving those numbers. But if you have the Pentacam in a non-totally dark room, those values can be affected by that because there'll be more light in the room. And the other thing that I'll say when it comes to difficult scans where the auto alignment has failed, if you are having trouble on a severe pathology patient because auto captures failed, Oculus and my department, the clinical application department, does offer a training on taking manual scans. So go ahead and reach out to us and we'll go ahead and help you out. All right, so for you, Ken, here's the first question.
Well, thank you, Carver, for answering all those technical questions. I appreciate that.
Perfect. So I think you kind of answered this slightly, but at what point when having difficulty capturing good data, do you recommend going to, some other based fitting set, like either fitting sets or impression-based design?
Okay, well,
or is there a point?
Right. Well, as far as fitting sets, I have countless numbers of lenses sitting in drawers collecting dust for probably close to 20 years now. I've really 100% abandoned trial lens fitting. I shouldn't say 100%, but it's 99 with a whole bunch of nines after that percentage. On a very rare occasion, I might reach for a lens just because I want to check something quickly. But for the most part, I really don't like to waste the patient's time or mine putting lenses on that don't fit well for a couple of reasons. Top of the list is it's a horrible experience for the patient. They've already been through enough, and putting lenses on that don't feel right, don't perform properly, or how many times have you put a lens on that's just hanging on barely, and you're trying to get some over refractive data and the lens pops off in the middle of all that. That's useless time to me, and it's inconvenient and very tough on the patient as well. And so you even see here in this particular case, even though I had checked numbers and even though there wasn't a real good matchup between some of the values that I had calculated based on the very difficult data that I tried to obtain, along with what I was creating in WAVE, my goal here was to use that first lens as the diagnostic lens. And by doing that, look at how much better the experience was for the patient. This is an eye that this particular patient had written off 20 years ago and hadn't even ever dreamed of getting vision back. And not only did I have a lens that was comfortable, but I actually gave her vision as well. That gives them a lot more motivation. So I felt I was close enough that I went ahead and designed up a diagnostic lens with that first lens, and that's what I used as my diagnostic lens. I actually prefer that. Now, as far as impression-based technology, that I'm not really going to get into. That's not really appropriate topic matter for here, but I do not do any impression-based technology in my office because that's not typically what I'm having to deal with, such as vaulting up glaucoma shunts and things like that. That's not the patients that I see, so I don't really use that technology in my office.
Perfect. Thank you, Ken. All right. So I have a question about central thickness, edge thickness, and when you have these more unusual eyes, how do you ensure that you have lenses that stay within those kind of ranges of maximum and minimum thicknesses?
I'm not sure I understand. Is the question based on the thickness of the lens being inappropriate and concern for example, oxygen on a graft? Is that what the question's about?
Specifically, it seems to be concerned about, do you ever get concerned about the lens getting too thin when doing a lens like this?
Well, one of the things that I don't think a lot of people are aware of is that when you take a look at the WAVE screen, I'm just going to back up a moment here and put up that WAVE screen just so we can have a picture of it. There we go. The picture where it says the lens profile up on the top, half of the WAVE screen, that's not just a pretty graphic. That graphic of the lens is a graphic that's being created by the actual file that is sent to the lathe. So that cross section is a truthful representation of what's going to be manufactured. So if you're taking a look at that screen, for example, at the image on the top, you can see nasal and temporal thicknesses are fairly homogeneous all the way through the dimension of the lens, yet in the superior and inferior, you can see that the inferior portion of the lens is considerably thicker than the superior portion of the lens in this particular design. As far as getting too thin, I always look at that picture to make certain that I have something that doesn't have any sort of strange little angles that may present a weakness in terms of the actual material's stability when it's getting manufactured, or if it gets manufactured, then once it's on the eye, that the patient can easily break it. So that's where I would be sort of observing to see if the lens is getting too thin or not.
Perfect. I think that's a great explanation for what that question was trying to ask and my interpretation of it. I have a few more questions for you.
Go ahead.
You talked about CSP measuring out to 18 pretty consistently. If you are fitting a 15 millimeter lens, do you need the data out to 18 millimeters?
You don't need the data out there at all, and the only reason I brought it up is that when I was using the standard CSP, I would consistently get out to probably 16.5 to 17 millimeters. On a rare occasion, I can get a little further than that, but you had to have a very cooperative patient. 16.5 millimeters, though, is just about where sort of the meat and potatoes of where you'd be fitting a lot of these scleral lenses are going to be in terms of diameter. And so if it's 16.5 millimeters and you start getting a little bit iffy in terms of the reliability of the data out there, that might concern me a little bit. When I get the data off the CSP Pro and I say I consistently get out to 18 millimeters, that gives me very, very good confidence in all the data that's inside there is incredibly reliable that I can go on. And I am not working hard to get out there. Due to the way that camera is mounted on there, it really is fairly easy to get out to 18 millimeters of coverage. The only time you start getting into very dicey situations when the cornea and/or sclera is very scarred up and things start getting a little tougher, just as with the scan in general. But it's certainly not to get out to the 18 millimeters.
Perfect. Let's see, the next question that I have for you. You mentioned making your patient comfortable, and I had a question or two about improving capture on dry eye patients. What do you recommend for those dry eye patients and things that are particularly successful in improving coverage for them?
Well, one of the nice things, obviously, and I've spoke about it before with the Pentacam, is it's not tear film dependent. So even if they're miserable, it's not going to affect the data that you're getting. So from your side, that's a very good thing. But of course, the patient is going to be very uncomfortable if you've got their eyes pried open and they already have a compromised tear film. For any of those people, or sometimes, again, on some of these very, very difficult to get scans on patients, because of all the scarring and things like that, sometimes I will put some proparacaine in their eye just so they're not so physically bothered by having to sit there and keep their eyes open while I'm trying to get a good scan. The proparacaine will not alter your data at all, and it does make the patient considerably more comfortable, and it is much easier to get their eyelids open. I do remember that I had one particular keratoconic patient who stands out in my mind. On the AXL WAVE, so on this instrument platform, even with the CSP Pro software, he had so much epithelial disruption. I mean, he stained up quite a bit that it was impossible for me to get his eyes open, even to see the cornea, much less the sclera. And I worked very, very hard, and the scan did take quite some time before we were able to get good, reliable data on him. And I would have been absolutely impossible without the being anesthetized. So, you know, it's not mandatory, but if you go to take a scan and you see that the patient's having any trouble, without any hesitation, I'll go ahead and put a drop of proparacaine in their eyes so that they're more comfortable. to sit for the scan.
Perfect. In these complicated cases, when you were doing kind of those manual measurements of the sag height, what display were you using? Kind of how are you accessing that data?
If it's the one where I was showing that I drew a 15mm cord and then I dropped down the perpendicular to get some idea of what the sags were, those are on the Shine Fluid image scans. And all you have to do there is pick the appropriate cross section. You generally have to turn the illumination down so you can, because the places where it's reflecting, you really can't see where the edge is. And so if you turn the illumination down, you'll get much less reflectivity and get closer to where the truth of the edge of the surface of the eye actually is. And then just drop down those measuring devices. They're right there on the Shine Fluid screen, and I'm sure your department over there, Carver, can train these guys on utilizing some of those tools as well.
Perfect. That is all the time we have for tonight. Well, we do have a few more questions. I'll go ahead and get those sent to you, kind of Ken, via email. Dr. Mahler, thank you so much for your presentation tonight. Do you have any final comments before we wrap up?
No, I think that the takeaway from tonight is that even when you're having trouble getting these scans, don't feel defeated that you're not going to be able to design up a lens. You do have to sometimes think a little out of the box as to how you can get a little bit better data. But in the end, try and do your best to get what you can that does seem reliable, design from there, get a lens on the eye, and then troubleshoot from there. This dates back certainly to the fact that I've been fitting scleral lenses well before scleral profilometry was available. It wasn't even a dream at that point. And so developing some of the biomicroscope skills is still valuable. And that is something that I do rely on daily when I do look at eyes. So being able to get the lens on the eye and then troubleshooting a little further from what you see at the microscope is incredibly helpful. Sometimes you can then go ahead and even do a scan of a lens on eye. I just had a very interesting case yesterday, in fact, that I had a very difficult time getting the virginal data off the cornea, but once the lens was actually on the eye, I went ahead and rescanned them, and I actually got reasonably good data because the lens took out a lot of the irregularities that were causing the problem for the Pentacam to try and make sense of what it was seeing. So there are a couple of ways out of the box thinking can really help you out over here. But the bottom line at the end is we're all clinicians trying to get a good lens on the eye, and that is, it is something that you're capable of doing just from this data, even when the data is somewhat compromised because of the troubles that you encounter. So get good scans, decide what you need to do with the data, and then design up a good lens and get it on the eye. That's about all I have to say about how to approach these cases, and they are incredibly rewarding.
Thank you, Dr. Mahler, and thank you everyone for joining us tonight. And on behalf of Oculus, have a good night.
Everyone have a great night.